I thank Professor Bhiman, Professor Amit Goel, Dr. Surendra, and Dr. Ajay for the invitation, and many congratulations on the inauguration of the department. My job has been made very simple. Are we missing a lot? The missing a lot component has been covered by Professor Pankaj Puri, and of course the staging systems by Professor Chavla, so that makes it really easy. Are we missing a lot? Yes, we don't have a cancer registry, which is incorporating the entire country. We have no idea when data is uploaded to these sites. So we don't have a clear denominator to determine who should be screened and who will actually benefit from surveillance. So we need to know what is surveillance, what's its importance in India, who requires it, and whom and when to screen. So surveillance for the students is just close observation of a large population. And what we intend to do is to look at the population at risk. Here it is everyone with liver disease, whether it is non-cirrhotic or cirrhotic, everyone with liver disease is at risk of HCC. And in this large population, we have to identify early the people who are at risk of developing cancer and manage to catch it at a stage when it is curable, such that there is population survival advantage. So that's what surveillance is. And the whole idea is that we should be using our existing technologies, which are also cost effective, to be enabled to be established across the country to prevent the death of that one individual in the large population. So we already know, and there's a lot of new data emerging from multiple centers rather than a global disease registry from India, that it is a leading cause of death now, and certainly for the patients that we are dealing with. And we also know by the Asian example of Taiwan and Japan, that if we actually surveil populations where there's endemic viral disease, or in our case, of course, NAFLD and alcohol is rising. So if these patients are actually surveilled, we can see they are doing much better than even advanced countries in Europe and in the United States. So if we detect by surveying that appropriately, we can prevent deaths, prevent and actually cure, have curative therapies in cancer. So if patients are detected at an early stage, not only do we have early tumor detection, twice as much as the surveillance, which is not being enforced, we have curative therapies rather than all the palliative or advanced expensive therapies, and we can actually prevent death in that individual. So who will benefit from surveillance, and how much is the government willing to pay or the taxpayer willing to pay? So an intervention will be effective if it provides a longevity of around 3 months. We know that if we have ablation or resection at an early stage, it's going to be far more than 3 months. And even with the early local regional therapies, we have increased survival. And the incidence, and this is wonderful, it's 1.5% per year. And Professor Puri showed it was 0.2 to 2 as per current missing data estimates in India. So interventions that can be achieved at the cost of less than 50,000 USD, so this is again US data, in gain of life per year will be considered cost effective at the population level, and the government would be willing to pay, or we would be willing to advocate for it. Not only are we talking about cirrhotic HCC, the increasing number of non-cirrhotic HCC is actually frightening. If we are to believe the data which is under review, up to 25% on that database. So this is surveillance. Again, these are patients with NAFLD or alcohol use disorders, maybe F2 fibrosis, whom these centers have actually looked for cancer and found it. So 25% of all HCC is now non-cirrhotic. So BCLC and all doesn't cover these patients at all. And we need to be thinking about preventing deaths in this large population group as well. So we should survey, and what is the yield? The yield would be the ones we actually, the number needed to treat or survey to prevent death or to prevent morbidity. So the definition of the target population is we need to know the incidence of HCC and cirrhosis at different degrees of fibrosis in all of the etiologies that affect India. We also need to know the probability that we will, if we survey them, we would be able to pick them up at a stage such that they are BCLC A or B, such that we can cure them. And the therapy is not too expensive, which Dr. Anand would be covering, which shows the expensive therapy. So we need to prevent them from getting to that stage. So the society guidelines are largely, they agree that everyone with cirrhosis, they need to be on that 6-monthly surveillance, and in all etiologies. And more so, you will have a higher diagnostic yield in child C. Naturally, they have more fibrosis, more regeneration, therefore more cancer. But are we going to enable them to have curative therapies if they are decompensated? Unlikely. So the surveillance should be even more intensive in those who will have a curative aim or liver transplantation. So surveillance for all recommended. It's still not clear what we need to be doing about HPV, especially in patients who are not having cirrhosis. So there's this PAGE criteria where we look at the platelet count, we look at the age, the male gender, and that gives a score of between 0 to 18 and provides a risk stratification in patients with chronic hepatitis B. So maybe PAGE and other criteria can be used. In HCV, post-DAA, there's still a risk of developing HCC even after viral eradication. So that's a huge group in the National Viral Hepatitis Control Program, which we cannot ignore. F3 fibrosis of any etiology, that's where NAFLD and alcohol become important, and NAFLD without cirrhosis. So that's a worrisome. So we need to know whom to survey, and this is what the society without cirrhosis. And of course, we know that patients with child A and B, these are the patients who are likely to get cured. So there's a very strong recommendation in EASL and in ASLD as well. But there's no data and it's unclear. And we need to generate that data as a society. So CPLD is a great place because 3 major centers and more can actually join hands and generate this data appropriately. Now, what should be the interval? So there's a 6-month interval, which is reasonable in most of the patients. And why we do it, I'll come to that. At less than 3 months, there's no clinical benefit, just increased cost. At more than 12 months, we will not pick them up early enough such that it is curative, because that's a doubling time of the tumor. So the timing is 6 months in all of the societies, except those where we have any intermediate nodule or more than 1 centimeter nodule, in which the duration of interval of surveillance would be reduced from 6 to 3. And I'll just tell you that. So what are the new innovations that have come that actually determine? So we know that if we are surveying too late, we will not get adequate survival because these will not be curative therapy. And therefore, this 3-month surveillance group will also have these non-specific lesions, regenerative nodules. So unnecessarily doing contrast examination in them would not be cost effective. So there's no need to do it so routinely. What's new? Earlier, we used to do just 6-monthly ultrasound, and most societies would not recommend use of any biomarker. This is non-invasive. It's very easily available. It tells about decompensations, portal vein as well, but it depends on the expertise of the operator, how willing they are to look at all the lobes of the liver. So it's not just giving the liver span and the portal vein report, but you need to spend time and actually scan over the entire liver to determine small nodules. And it also depends on the quality or of the machine. So new innovation, we need to define which is a dysplastic nodule, which is an HCC, which is a suspicious nodule. So LIRADS is liver imaging reporting and data system. So LIRADS should be the reporting right from ultrasound to CT and MRI. We should uniformly follow this criteria. So we all know what we are talking about. And we can compare our data across hospitals, across societies. So in LIRADS for ultrasound, a US1 would be LIRADS negative. So that's definitely going to be benign. US2 would be a sub-threshold or less than 1 centimeter. So this is a 0.6 centimeter nodule. This needs to be investigated further with a contrast enhanced ultrasound or with dynamic CT or MRI, or maybe we resurvey after 3 months. And then in patients who are having more than 1 centimeter nodule, quite distinctive, and we use something called the visualization score. This is also going to determine us to classify the lesion. So this is LIRADS for ultrasound. Coming to the biomarkers, this is what we had earlier. Now, AFP is an embryonal biomarker. So it's a marker of de-differentiation of cells. It means that these fecal oncoproteins are being produced. So the de-differentiation is actually a late stage. So what do we do about the screening cutoffs? Well, AFP is high if it is more than 20 nanogram per ml. But we know in patients with HBV flares, autoimmune flares, or if there's any viral hepatitis, the AFP might actually go up temporarily, which comes down to normal. So looking at AFP serially may make more sense in the same patient than giving a universal cutoff for the population. And if you are going to take a very high cutoff, like I said, this is a de-differentiated protein. So that means that the patient will be detected very late. So a combination of ultrasound and AFP is actually going to be cost effective in India because these tests are available at a low rate. We cannot advocate for doing contrast enhanced imagings in all of them. So AFP, I would say a cutoff of more than 200 is nearly diagnostic, but it will not be useful for surveillance. So maybe looking serially at AFP and looking at the 20 to 200, it means they need to be on more rigorous surveillance. Other biomarkers, there's PIVCA, which is protein-induced and vitamin K absence. It is typically associated with vascular invasion. So again, not an early biomarker, not good for surveillance. AFP-L3 is not recommended. It is not sensitive enough because it's a subtype of AFP. There's this GALAD score that one needs to be aware of, students, and that includes AFP-L3, the DCP, age and gender, because all of these are independent risk factors, and it actually increases the sensitivity for diagnosis and the specificity. MicroRNA liquid biopsy is not useful for population surveillance, which is my topic. But in the future, with NGS becoming more and more cost effective, maybe those early and intermediate modules in patients at high risk of HCC, it might come into play in personalized medicine. And there are other research molecules like osteopontin, glypican-3, and microparticles, which may be of use, but again, not part of surveillance, but you need to be aware of this. So coming to CT and MRI, not useful for general surveillance. We cannot recommend it. It's not going to be cost effective to use these. And there's radiation risk in CT and there's high cost of MRI. So what do we do in this case? Again, the LIRADS lexicon needs to be very clear, whether it is not classifiable tumor in vein, whether there is LR1 and LR2, which is largely benign, LR3, where you're going to have a high probability of malignancy, and our center, LR3, if we do a biopsy, which we're doing a tissue diagnosis for all, more often than not, it is malignant, and 4 and 5 is definitely going to be malignant. So these are the standard definitions that you need to be looking for in your CT or MRI report. And if it's not there, you need to confront your radiologist and start demanding, because that's when we can have a database which is uniform across the country and develop the registry that Dr. Puri was asking for. So the diagnostic table and the definitive criteria, you can look at the LIRADS document. It is available freely for download. And the ultrasound LIRADS scoring is also something that we can incorporate into our practice to ensure there is uniform assessment or during surveillance. So there are a number of ancillary lesions which you can look for in your CT and MRI reports, whether there's fat and mass, whether there are perfusion defects, iron sparing, fat sparing, and all of these are going to tell whether it is more likely or less likely to have a malignant etiology, right? And coming to the BCLC, when it is not incorporated in the BCLC, but if we look at the kind of gradation from negative tuber nodules where we have routine surveillance, or the non-classifiable variety where we need to do it maybe early, or any of the LIRAD stages, so we need to reduce the interval and increase the frequency of surveillance based on these reports. So insist about good reporting from your radiologist. Another thing that we have started doing at PGI, and this is a protocol that's being done at multiple centers in the US, is to look at abbreviated MRI. So we don't want to give too much of contrast. That's expensive, the liver-specific contrast. And we don't want to occupy our machines for doing surveillance for everyone. So in patients who are having an ultrasound with an indeterminate nodule, we subject them to an abbreviated MRI. It is costing us just around 1,500 per patient, and it is done in 15 to 20 minutes. And hopefully by next year, we'll have more data on what is the extra yield that we have got by incorporating it in our cirrhotic patients. Mind you, we are doing this in cirrhosis. We have not yet started doing it in non-cirrhotic patients. So again, willingness to pay. So this is an example of an indeterminate nodule that was found on the abbreviated MRI. And then on the, the ultrasound, when we give contrast, you can see there was some enhancement, and on the abbreviated MRI, we picked it up. And look, it is a symptom-free patient under surveillance. This was a patient with viral hepatitis and had a curative ablation. So that's the utility of looking at and picking up these patients quickly. So the surveillance interval will change, and we need to incorporate maybe in the next NASL guidelines about what to do in patients without cirrhosis. And we need to actually reflect about the specific etiologies at our center. So in Punjab, for some reason, we are having a lot of Hep C, maybe because we are actively looking at the population and giving free DAs, Hep B and vaccination, the balance between treatment and ensuring the population coverage with the vaccine. How? I will say definitely ultrasound and DFP, because they are complementary, because we are doing it serially in the same patient. Then every 6 months, be careful about how you counsel the patients, because there are false positives. There is a financial burden. So I think the government needs to step up in the willingness to set up a registry and pay for surveillance, because it is useful at the population level. So this is my summary slide. The take-home message very clearly is ultrasound every 6 months. Think about non-cirrhotic patients with HCC, patients male, diabetics, multifactorial age, that is, they're obese, have diabetes, plus HCV, plus alcohol, these multifactorial etiologies. Even a small nodule needs to be surveyed more carefully. So take a good history. And if there's a patient with in the family with HPV, screen the entire family. That would be a very cost-effective way of actually managing and treating patients early with HCV. So that's my take-home message for surveillance. Please incorporate it in your practice. And lastly, the Indian journals are really important. So rather than looking at gut and gastroenterology, read our journals. It is more in tune with our requirements and our patients. Please cite our journals, read them. There are a lot of wonderful new things that have been done at JCH and IGG, and please cite us. Thank you very much.